So we can get started. It's 8 o'clock, and it's our distinct pleasure to have Dr. Sean Wharton from Toronto speak to us about advances in obesity medicine with a focus on renal failure. So Dr. Wharton runs he's the medical director of the Wharton Medical Clinic, which is a community-based internal medicine, weight management, and diabetes clinic. He's got a doctorate from the University of Toronto in pharmacy and medicine. He's got affiliations with McMaster and York, and he works at the Women's College Hospital as well as the Hamilton Health Sciences. For today's topic, of course, he does a lot of research on obesity, medicine, and diabetes, and he's a lead on the Canadian Canadian Obesity Guidelines that came out a few months ago. He's also been involved in activism for health equity, and he founded the what some of you may know, the Black Medical Students Association, way back in 2000, and it's now a recognized mentorship organization across Canada doing great work. So we are really happy to have Sean here today. Please go ahead.
Terrific. Thank you very much. And I have to thank the team at the Ottawa Hospital, and also really thank Anne Bajaya for asking me to actually do these rounds. And Anne was in my class, and I was trying to look up some embarrassing pictures of your fellow nephrologist Anne Bajaya from the time that we were in med school. I couldn't find any. That back in the day, you didn't have the cell phones and such to take pictures. So we'll just proceed without that. So today, what I wanted to do is I wanted to talk about advances within weight management medicine, and we call it obesity medicine with a little bit of a focus on renal failure. So here are my disclosures. And the learning objectives today are going to be to understand the neurophysiology of obesity, understand the application of the Canadian Obesity Guidelines, and we're going to focus in on renal failure. So first, I want to say a bit about me. Here's my wife and my two babies. So my wife's a GP here in Toronto, and here we are with baby James. That's first baby, born 2020, and my second baby, which is the Canadian Obesity Guidelines, which were also born or published in September 2020. So, also as well, I was at the University of Toronto for my medical school, but my residency was at McMaster. And I was interested in hypertension, particularly hypertension in Black people, trying to figure out what was happening there. My mentor was Dr. Arya Sharma, who is a nephrologist. And at that time, Arya Sharma was interested in obesity medicine as a
I think we lost you there.
I think it's appropriate for me to do it. Go ahead. Am I back?
Yeah, you're back. You're back now. I think we lost you briefly there when you're talking about Arya. Please go ahead.
Arya. Oh, right. Okay. So terrific. So as I said, I was looking at hypertension in Black people. Arya Sharma was my mentor. He is a nephrologist. Was interested in obesity as it affected the kidneys, as it affected hypertension and other comorbidities. So it's appropriate for me to do a nephro talk, seeing that was some of the background that I came from in terms of looking at this. So I run the Wharton Medical Clinic. It's mainly a clinical space, but it's also an academic and a research center. We have a number of internal medicine doctors working with us, and a full staff that works to work in the obesity and type 2 diabetes field. We've seen approximately 500,000 patients, most of them women, 76%, but 90% of them have consented or signed the consent for me to publish their research, to publish the data on them. And that's where a lot of the research ends up coming from. So let's go into a little bit about obesity medicine, where it actually is now. So let's start off with a bang and start off with the obvious, is that obesity is a pandemic. It affects 13% of people across the globe. That's 650 million people. Here in Canada, it's 26%. In the US, it's 40%. So there's no single chronic metabolic disease that is more prevalent than obesity. So obesity is responsible for many medical conditions, as you can see here. And treating obesity treats these conditions. But of course, this isn't new news that if you treat obesity, then you will be able to deal with fatty liver. It's in the name, fatty liver. But of course, the challenge has always been treating obesity. I've never been good at it. So what about obesity and renal disease? Well, 44% of people in the US with chronic kidney disease also have obesity. So this can complicate treatment of CKD. And 20 to 25% of CKD is believed or likely to be caused by obesity as a direct cause. So how much weight loss does it take to improve these medical conditions? Well, it is a lot of weight loss and it needs to be sustained. We used to say a small amount has a major impact, but what we know is that is not entirely true. A small amount of weight loss has a small impact. That impact is often lost quickly. So let's look at type 2 diabetes. Diabetes prevention starts at 3%, but a small amount of weight loss, again, are often unsustainable. So we need to focus on the arrow on the right, indicating that more weight loss is actually better. We need sustained weight loss of 15% for diabetes remission. A new chapter of the Canadian Diabetes Guidelines comes out on Friday, tomorrow, and it is discussing remission. And the main factor will be weight loss. So remember that all of these parameters revert with weight regain. So the emphasis here is sustainability. So how well have we been doing with weight loss? This Canadian study from my clinic, we looked at over 7,000 patients over 7.5 years doing lifestyle and doing diet. We put all the data into the computer to come up with patterns of weight loss. We came up with these 7 patterns. So let's focus in on this in the center. The purple and the yellow lines representing weight stability or minimal amount of weight loss. So you can see in the rectangle, that is the amount of weight loss that we saw for a good percentage of our patients. So 2/3 of our patients only lost, either were weight stable or lost 2.3%. So that's a placebo arm that we see in most clinical trials, between a 2 to 3% weight loss. There was a small number of patients, 2.3% of patients, that lost 21% of their weight. Clearly, that's where we want more people to be, but that was only a small group. The majority can't lose significant amounts of weight and keep it off. So this is a meta-analysis showing the exact same thing with several studies, gives us the same data. No matter what we tried, we could not maintain weight, and all the graphs look like this with weight regain. The first part of the graph always gives us hope, and then our hopes are dashed, usually around the 6-month mark and definitely at a year. From a physiology standpoint, we know that the counter-regulatory effects start early and win the battle by 6 months and definitely the 1-year mark. But today is a new day, and treatments have dramatically improved. So how did they improve? How did things get better in this field that's been so dormant and so challenging for so long? Through the understanding of neuroscience. So understanding that obesity is a genetic disease is what helped us here. So the main thing is that these genes drive mechanisms that protect against weight loss. So the 3 areas of the brain most involved in this genetic coding and driving obesity are depicted here. It's the hypothalamus, the mesolimbic system, and the frontal lobe. They're all designed to protect against weight loss. The intensity of that protection is dictated by the intensity of the genetic code. So let's look at the hypothalamus. It's the easiest to actually understand. This region of the brain controls functions that are really automatic, such as heart rate, blinking, of course, and we have some cognitive control over it, but we don't have much. It also controls physiologic hunger. So blood sugar goes down a bit, it goes a little low, hunger kicks in, it's automatic. And the hypothalamus cares very little about stored energy in the fat cells. Ghrelin increases the hunger. Therefore, this is a logical molecule for us to try to block. We've been working on a blocker. We're not there yet. And the rest of the hormones listed there all make you feel full. Therefore, logically, we should try to increase these hormones or to offset the caloric intake. And if you look at these hormones, these are the molecules that we're using to treat obesity. We're using analogs of most of these molecules. Let's focus in on one of these molecules for a second. The most popular one is the GLP-1, but let's talk because there's an analog for it. Let's talk about leptin though. So leptin was one of the first hormones that was identified as a molecule that helps us, that works in the hypothalamus in terms of controlling weight. So leptin comes from the fat cells. So when you have a lot of energy, you dump it into the fat cells start to release leptin to tell the brain to stop eating and increase the metabolic rate. The interesting thing is that we now have to figure out, people living with obesity, do they have a lot of leptin or a little bit of leptin? Remember, leptin is a positive hormone. Many people would say they would have a little bit of leptin because clearly weight is a challenge for them. But the answer is they have a lot of leptin. They have a ton of it because leptin is produced by the fat cells. So the thing here is that then why isn't the leptin working? What's the problem? What they have is leptin resistance. And of course, and we don't know why they have leptin resistance, but it's genetic. And the question is do we know any other hormone where there's a ton of it around and we have resistance to it? Of course we do. Insulin, and then that is type 2 diabetes, insulin resistance. So you can see here that we're in the same realm. Obesity hits a lot of the same markers that many other chronic diseases do. So the mesolimbic system is probably much more interesting and probably needs to be our main target, as well as the hypothalamus. This area of the brain is the hedonic eating. And God, whoever she is, decided that only intense hormones can control this particular area. And it's always working. And it works with dopamine, opioid, the cannabinoid system to make sure to do two things really well for survival. Those two things are sex, reproduction, and eating. So we have some control over hedonism via our executive lobe. That control is limited. Our control is best when we are rested, when the executive lobe is not stressed. So when that executive lobe is taken up by other things, a very challenging day, or you're tired, or it's in the evening, that's when you eat or overeat. That's when, if you're stressed, that's when your eating happens more. When you dull your senses with alcohol and you're dulling the executive lobe, it can't control the mesolimbic lobe any longer. That's when excessive eating and hedonism happens. So you can see that these are some of the factors. And if we can have medications or treatments that work in the mesolimbic lobe, that will work out better. Also, if we can enhance the function of the frontal lobe, we can have a better chance at treating obesity. So we wrote the Canadian guidelines with a focus on this science. We also felt it was important to focus on bias, stigma, and discrimination that plagues this field. So once we address the bias, we can actually focus on the science to attain the real wins in medicine. So I'll talk a bit about bias. But here we go. These guidelines were the #1 most read medical paper in Canada in 2020, the year of COVID. And it's made it around the world. So it was surprising, the year of COVID, that this article, was the most read. So, and I think it made it around the world and was so popular, likely because we addressed bias and stigma. So let's look at who has obesity bias. And that is a negative impression of people living with obesity. So who here online, who can we say has obesity bias? Well, it's all of you, everybody. Almost everybody has obesity bias. Everyone online, I have obesity bias, a negative impression of people living with obesity. Now, how can I be so sure that I'm saying this about everybody that's on the line here now? Studies show that obesity bias starts in preschool. If you show preschoolers pictures of a child living with obesity versus a child with a disability, the preschooler will never choose the child with elevated weight as a playmate. They also start to assign negative attributes to those with obesity, like laziness, lack of intellect, and other harmful traits. This bias continues well past preschool and is seen in doctors and healthcare providers. 70% of people living with weight and obesity say that they experience stigma from their healthcare providers. So we have to be cognizant that this is part of our milieu. And then we have weight stigma. And what is weight stigma? Weight stigma are stereotypes, or those negative images that reinforce our biases. Or they can sometimes create our biases, but they definitely reinforce them. So let's do an activity. Many of you are on your computer, some of you maybe. Well, if you're going to do a presentation and you want to put up a picture of a man living with obesity in your presentation, let's Google man. Let's put in search terms obesity, man, and images. And let's see what you find. 72% of the images that you find will stigmatize people with obesity. That's a real shame. Images of men wearing their clothes too small for them, riding up their bellies as if they don't know how to dress, or images of them in unflattering positions. It's hurtful, it's belittling, and it should stop. So if you belong to any group and you see images of your people in this negative way, it will make you terrible. So instead of these images, Obesity Canada has an image bank where there are free images of people living with obesity who are active, moving, and dressed in an appropriate fashion. So these images are the ones that we should be displaying. Also, let's stop using the word obese. It is obesity, person first language. So not obese Jane or obese people. We're putting Jane first. Jane with obesity, people living with obesity. So to be able to combat all of this bias stigma, we the Canadian guidelines looked at deciding that they would use the 5 A's. And the 5 A's, really the first A is the most important A, and it's about asking permission to discuss obesity. So if someone's living with obesity and you're treating them and you want to discuss obesity, you have to ask them why, because they've been injured for so long, because we have spent time being biased and stigmatizing them. So they don't trust us. So we need to develop that trust again and the compassion. Saying things like, we now know that obesity is a chronic disease and the way we treated people in the past doesn't work. Would you be interested in addressing your weight at this time? Again, this shows the compassion. Now let's look at the pillars that support long-term weight loss. The 3 pillars that support medical nutrition therapy, which is diet and physical activity, are psychological intervention, pharmacotherapy, and bariatric surgery. All 3 of these interventions work in the brain to impact neurochemical changes. Let's start with the gold standard treatment. For those living with severe obesity of BMI greater than 40, or BMI between 35 and 40 with a comorbidity related to obesity, bariatric surgery is the gold standard. It has the best evidence for success and for sustainability. So here we see that the gastric bypass and the gastric sleeve, you get 30 to 35% weight loss. The important thing here is this is not a restrictive surgery, but a neurohormonal surgery and a metabolic surgery. And we'll talk about the mechanism. The mechanism we believe, because there's still science to be learned here, is that after you've done the gastric bypass, so the food is not completely digested. So semi-digested food gets to the small intestines, gets to the ileum. In the ileums, we have the L cells. The L cells are the incretin cells. You agitate the incretin cells and they release incretin hormones. Incretin hormones go to the pancreas and to the brain to tell the body that you have received energy and what to do with it. So the pancreas is going to release insulin and store the energy in an appropriate way. And the brain is going to say, I've received lots of energy, stop eating. So after the bariatric surgery, there's a flood of these positive incretin hormones that tell the brain to decrease eating and to keep the weight down. And that's what we're actually talking about here. So one of my favorite pillars, though, is moving from the surgery pillar to the next pillar, is the psychological intervention pillar that strengthens the frontal lobe and builds up the defenses against hunger and craving. CBT has been used for many years for a number of conditions, but it's now a primary treatment for obesity. Understanding emotional eating versus physiologic hunger, understanding resilience patterns, and self-love are all methods of maintaining weight loss. And we're getting better at these treatments. The guidelines recommended that we avoid the use of the word diet. So let's talk about this diet part and replace it with MNT, medical nutrition therapy. So MNT is the evidence-based use of dietary options to treat medical conditions. And we have evidence for treatments of hypertension. Everybody knows what that diet is, the DASH diet. Everyone knows what the diet for heart disease is, the Mediterranean diet. But we do not recommend a specific diet for weight management. There isn't evidence for a specific diet for weight management. Instead, a healthy eating approach, leaving the ability to achieve lower calories to the 3 pillars. Again, you need lower calories to decrease weight, and the 3 pillars end up getting you there. So will medications be effective? What do we have? Well, previous medications have failed us and were taken off of the market, but today is a different day. New, better medications have been introduced and are changing the game. Based on this science, there are now options for better pharmacotherapy. We have some medications approved in Canada and emerging medications. Orlistat was the earliest medication to be approved in 1999 and clinically resulted in very little weight loss with poor tolerance. And as a result, it is not used much. Liraglutide was the first truly effective weight management medication to come to Canada, a GLP-1 analog. The first time patients got some relief from their obesity with this daily injection, up to 9% weight loss in the completers. And look at the placebo arm, it's saying exactly what it should, between 2 to 3% weight loss, right? So the primary side effects here were nausea, impacting up to 40% of patients, but this is tolerable, it's transient, it works out properly in terms of titrating the dose. So we did a real-world study with liraglutide that got promising results up to 7% weight loss. Remember, in the clinical trials, it was between 8 to 10%. Now, we got 7%, which was good for a real-world study. We also saw nausea as a side effect, but we also know that constipation was a challenge for a number of patients. Second medication to hit Canada was the naltrexone bupropion combination contraste. Now, this is an interesting medication, the way it works. So the bupropion component stimulates the POMC neuron. This releases alpha MSH into the neuroleptic cleft. Alpha MSH goes to the MC4 receptor. The MC4 receptor is responsible for weight loss. The unfortunate thing is that the alpha MSH is pulled back into the POMC neuron by a reuptake mechanism. This reuptake mechanism works through a opioid receptor. So the idea is and because this happens, it inhibits further weight loss because there's not enough alpha MSH. So the question is can we block this opioid reuptake receptor and allow more alpha MSH to happen? And we do that with naltrexone. So it blocks the reuptake receptor, there's more alpha MSH in the cleft, and we get sustained weight loss. So this medication gave us overall about an 8% weight loss. POMC neuron is in the brain, by the way, of course. So overall, we're seeing about an 8% weight loss here. And we saw improvements in cravings, which can be a real problem for many patients. Main side effect was, again, nausea. So the medication cannot be used in patients with a seizure history or those on opioids. There's also challenges with those with uncontrolled hypertension, and also it can cause some insomnia if the medication is taken late. If it's taken early in the day, it works out. So neither of the previous medications cracked the 10% weight loss range. With semaglutide, at 2.4 milligrams, we finally reached that 10% weight loss range. So this is another GLP-1 analog. It's once a week. It's an injection that was first approved for type 2 diabetes, but it's now approved in America, in Canada, and the UK for weight management at the 2.4 milligram dose. We published this paper in Journal of Medicine 2021. So here we saw double weight loss up to 15% in patients without type 2 diabetes. Actually, that paper was published in 2020. So here we saw double weight loss in patients up to 15% in patients without type 2 diabetes. We now have sustainability data, and this was the step 5 paper, where we saw 2 years of weight loss, again showing that we were able to sustain that 15% weight loss over a 2-year time frame. Remember at the beginning of the talk, I said sustainable weight loss is what we actually really is what we really need. And this is the impressive aspect, the reason why people call this a game changer. Is 1/3 of patients got to the surgical weight loss range, which was greater than 20% weight loss. So this was the first time that we saw a medication get into the surgical ranges of weight loss. So the main side effect was, again, nausea dissipating over time. Here in this DEXA study, we're seeing that patients on semaglutide, the weight that they lost was mainly fat mass. They were able to retain muscle mass. So focus on these figures here. The yellow is the fat mass percentage. It decreased, and the orange is the muscle mass percentage, and it increased. Whereas the ratio in the placebo arm does not change. So this was a positive indicator for what we may see in regards to metabolic complications of obesity, which is driven by the white adipose tissue, right? That went down, muscle mass ended up going up as a percentage. So both the systolic and the diastolic blood pressure significantly improved with bigger numbers of improvement than we've seen with other weight management medications. As predicted, the lipids improved with the bad cholesterol going down and the good cholesterol going up. Inflammatory markers improved, C-reactive protein decreased. For many investigators, this was a very important marker connected to inflammation caused by the toxic adipose tissue. And here we can see that the main side effects were, again, the GI side effects, nausea being the number one, seen in about 40% of patients. And again, this side effect is primarily at the beginning. And as you can see that it dissipates over time. The constipation line, you can see that one stayed relatively stable. So what we see is that people who had constipation before they came into the trial continue to have it. And it doesn't change much, but it's often manageable. So the newest agent is the molecule Tirzepatide. This is a dual agonist of GIP, which is another incretin, and GLP-1, treating both diabetes and also weight. So we published this article again in the New England just earlier this year. So spring of 2022, we saw this paper coming out. So what are we seeing here? Well, there was big news here, as many of you may have already heard, that the average weight loss here was at the 20% range. So in the completers, we got almost to 23% weight loss. So if we think about this picture, we can think about the fact that the first round of medications, the liraglutides and the naltrexone, bupropion combination, that was about the 8 to 10% range. The second group is the semaglutide 2.4, getting us to about 15% weight loss. And the third ranges of medications are going to get us up to 20% average. 20% average means that there are people 25, 30% weight loss. I like this graph. It is a waterfall plot. And at the bottom, you can see that's the Tirzepatide at 15 milligrams. This is a weekly injection. You can see to the right are the people who lost weight. So 97.7% of people lost at least some weight, with a number of them reaching to significantly higher weight changes. Averages, again, 20%, but many people reaching 25, 30. And again, the main side effect is nausea, around that 40% range. So again, seeing similar side effect profiles that we would expect from the GLP-1 analog group. So let's talk about the renal adjustment of these obesity medications. So orlistat, there's not studied in renal impairment. There's likely no dose adjustment needed here. It's mainly a gut-based medication. Liraglutide, there's no dose adjustment noted in the mild or moderate failure, but it's not recommended in severe renal insufficiency or end-stage renal disease limited to their clinical experience. Now, Trexone bupropion combination, it stated that you need to decrease to 1 tab moderate to severe renal failure. It's normally 4 tabs daily. 4 tabs a day, you'd have to decrease to 1 tablet daily. And it's not been studied in mild renal failure, and also, it's not recommended in end-stage renal failure. And semaglutide 2.4, there's been no dose adjustment in mild and moderate renal failure, and it's not recommended right now in severe renal insufficiency or as well end-stage renal to the clinical experience there. So of course, everybody knows where we're going with a lot of this. Does this result in mortality benefit, particularly improvement in cardiovascular outcomes, improvement in renal outcomes? So this is where diabetes management is way ahead of obesity management. We have not been able to demonstrate cardiovascular morbidity and mortality outcome in any trial to date from decreasing weight, except for some surgical trials. And those were some retrospective studies. So the reason why we probably have not been able to demonstrate cardiovascular outcomes is because of the inability to sustain the weight loss. So to get into the big leagues, weight management needs to show cardiovascular benefit and keep the weight down to be able to actually show that. So enter the SELECT trial. This is a bold trial trying to do what no other trial has done in the past and number failed, to show cardiovascular improvement in weight within a weight management study in people without type 2 diabetes. This trial has enrolled over 17,000 patients. Results should be coming out in 2023. So we're hopeful that we're going to see something positive here, but we'll have to wait and see. So let's talk about obesity in chronic kidney disease. So as stated previously, obesity is estimated to account for approximately 20 to 25% of kidney disease worldwide. But this is likely an underestimation if we consider that type 2 diabetes and hypertension are the 2 most common causes of chronic kidney disease, and that obesity is primarily responsible for type 2 diabetes and has a significant impact on hypertension. So we can see that it's probably more than that 22. The presence of obesity increases the lifetime risk of chronic kidney disease by 25%. So what about renal transplant? So we know there's higher rates of wound complications, longer hospital stays, delayed graft function, graft failure, and even higher mortality. Many transplant centers do not offer transplant to individuals who are above a certain BMI cutoff. This has been challenged at times because of the benefits that we see regardless of even of these complications. But again, we see that it does complicate things. So how does obesity cause chronic kidney disease? What are the mechanisms behind it? Well, to tell the honest goodness truth, we don't exactly know all of the mechanisms. And we believe it's primarily, it could be a direct effect and the indirect effects. Some of the direct effects are due to the adipokines and the toxic markers that head to the kidney and cause kidney damage. A decrease in adiponectin, which is a protective mechanism, increases resistance, and a number of other adipokines. We also see because of the volume, we have a number of other RAS activations, the inflammatory, the oxidative states, the higher insulin levels, insulin resistance patterns. Of course, if we lump in the type 2 diabetes, hypertension, and cardiovascular disease caused by obesity, we again see the chronic kidney disease happening. So what about this aspect? Numerous observations studies have found protective association between obesity and survival in end-stage renal disease, phenomenon known as the obesity paradox. So and it's particularly pronounced in older patients on hemodialysis. So we see this paradox also in the ICU, heart failure, and in COPD patients. Note that all of the conditions that I've mentioned are catabolic conditions. So this topic is controversial, and it's not been resolved what exactly happens here. But the considerations is that BMI may not be a good measure. So some of the considerations here is, again, that BMI may not be a good measure of health. And those with comorbidities associated with obesity, with their obesity, do not do well. I.e., if you have type 2 diabetes, coronary artery disease, a number of things connected to your obesity, then having obesity does not confer that benefit. But if your weight is primarily in the subcutaneous fat stores, i.e. the non-toxic fat cells, then you may not be at risk for within end-stage renal disease. And you'll also benefit from the extra stores of energy during your catabolic state. That's your COPD, your hemodialysis states. So the greater reserve in the short term may be beneficial, but it appears that long-term effects of visceral adiposity almost always a deleterious effect. So does weight loss improve CKD? So weight loss improves albuminuria, your GFR function, your development of CKD, and the need for dialysis. So most of these studies, many studies showing this, most of these studies though are short-term dietary studies, and mainly dietary studies. Again, short-term because weight loss was not able to be maintained long-term in any dietary study. So medication trials to show improvement are actually minimal. Liraglutide has shown a decrease in the new onset of macroalbuminuria in 9,340 patients that were in a randomized controlled trial, but it did not show improvement in the doubling of the serum creatinine, the renal replacement therapy, or renal death. So, but we do have some other evidence in this study, this bariatric study. It showed that it improves all causes of mortality by 31%. So decrease it by 31% in patients who have severe obesity and are on dialysis. So the question is if you're going to start an obesity-based medication, how long does one have to stay on these medications? So we just published this a few months ago, looking at weight regain after withdrawal of semaglutide. At the end of the step 1 trial, as we do with any trial, we stop the medication in participants. In this case, we monitored the patients to see what happened. There was no lifestyle advice given, no placebo injection, just monitoring. We monitored them for 1 year. So this may become an issue at some point, as you can imagine what the results were. So patients significantly regained the weight they had lost, and the cardiometabolic effects also reverted back towards normal. Patients with the most weight loss had the greatest amount of weight regain. Stopped monitoring at the 1 year mark. And as you can see, there was still some weight loss around 5%. Those with greater amounts of weight loss at the beginning, when we stopped the medication, had greater levels of retained weight at that 1 year mark. I believe that the weight would have gone all the way back up to baseline if we monitored for a bit longer. So there's a plateau there, which kept on moving up. But this trial told us exactly what we've been discussing for a long time. The counter-regulatory effects never go away, not change the set point, simply adjust the factors driving weight regain. And here we have the blood pressure returning to baseline or even worse. And interestingly enough, C-reactive protein was slow to end up reverting. You see that there. So I don't want to use the word legacy. So, but it's unclear what is happening, but it's good that the C-reactive protein didn't go right back up, but it is going in the wrong direction. And the A1C, as you can see, it goes back up. So all the pre-diabetes improvements that we saw in this trial, this was a non-diabetes, pre-diabetes trial. Well, the pre-diabetes got much better, but it went back towards normal. So for current weight management interventions, they need to be continued. They've not been, we've not cured the obesity. The interventions are just the broken physiology. It does not permanently change the set point. This challenges the bias that most of the world has about obesity, that it's just a character flaw, that the interventions are just a stopgap to improve a person's character. So in terms of the conclusions here, science and not bias should drive our understanding of obesity. Brain neurochemistry and genetics drive obesity. Cardiovascular trials are pending. CKD studies need to be done. Treatment is lifelong. And the game has changed. Effective obesity management is here. It is evolving. It is still new, but there definitely has been a big game change here. So thank you. This is my academic staff and my clinical staff. Thanks for your time, and I think we've left enough time for questions.
Thank you, Sean. That was a really fantastic presentation, a really nice overview of the whole topic. I think if you stop sharing, you should be able to see all of us and see our faces, which may help with the Q&A. So we have a large group of attendees here. So please raise your hand in the chat or unmute yourself if you want to ask questions. While people are doing that, if I'll start the ball rolling, saying, what do you think about, should these agents, these newer agents, they make it so easy compared to, or sort of easy compared to counseling, saying, hey, don't eat this, don't eat that. Is this something that should be still handled by, experts like yourself? Or do you think the broader community of practitioners should take up doing this? Is it something that, a nephrologist should prescribe, or maybe, there are other things that are important and we should, leave this in your hands?
Great, that's a good question. I think everybody ought to do this. There's no way for specialists or specialist centers to actually care for people living in Canada. There's way too many of them. So if a family doctor can't treat hypertension, they need to get out of medicine. So in 1930, you wouldn't have been able to do that, right? Because we didn't have good pharmacotherapy agents. But now you actually can. So everyone can treat hypertension, the run-of-the-mill hypertension. Challenging hypertension, you go to a nephrologist, right? But 95% of it should be treated by all doctors. 95% of obesity should be treated by all doctors. You do not need specialist care to actually treat it. And so you don't need special diets, as stated in the guidelines. It doesn't matter what diet the person's on. Weight Watchers, Jenny Craig, their cousin's diet, their uncle's diet, their favorite intermittent fasting, keto, doesn't matter. You are not the dietitian. You don't need to send them to a dietitian. You need to put them on the medication so they can adhere to their favorite diet, as long as it's a healthy dietary intervention. So no, it does not need to be in our hands. It has to be out of our hands, and it has to be in everybody else's hands.
Thank you. I love that. Manish.
Hey, Sean, how are you? Nice to see you. It's Manish Sood.
Very good to see you. Thank you.
Our U of T alumni days. That was a terrific talk. I really loved the slides that were all pictures with very few words. I thought that was very engaging. I do a lot of EDI-related work here at the Ottawa Hospital Research Institute, and we promote people to do the implicit bias training. And I was absolutely shocked when I did it for myself. My largest bias by far was obesity. I had no idea. I just found that tremendously insightful from a personal level, and it's kind of changed my perception and maybe some of my verbiage and how I interact. So that's just a comment, and I encourage anybody to take the implicit bias training because you may be in for some shock. The question I had was about discontinuation of semaglutide. I thought that was really interesting data. Is it that, I've had talked to patients on semaglutide and they're like, I don't even want to drink water. I just have no appetite. And I've always wondered, is the rebound that the appetite returns, do you think it could be blocked if we did jump in with interventions, or is it more, no, we just got to keep these people on these drugs forever?
Right. So excellent question. And what I think we should have done in that study, thanks for that, Manish, and thanks for the comment on the bias, internalized bias. So I think so. What we should have done in that study is we should have tried a lower dose of the medication, seeing if those patients that did really well, they don't want to stay on a high dose forever on the medication. Could we go on a lower dose versus those who don't go on anything? Could we give some of the patients cognitive behavioral therapy, active, real, intense cognitive behavioral therapy, and see whether it actually works? And so our impression is that going on to another diet or trying to do the intervention without any medication or any of the 3 pillars, which really would just be a different dose of the medication or a different medication, even maybe a lighter one, etc. That would be possible. But if you've come to the stage where obesity is a neurochemical condition in your brain and you're on a medication because it's an issue, the chances that you'll be able to keep the weight off over the long term without anything is relatively low. But I do think that we can do things like intermittent dosing or the patient owning the dose. That's because they're the ones who feel it. This is an objective measurement. I'm feeling too much loss of hunger and I can't deal with it. Well, decrease the dose so you can feel a little bit better. I'm working out with a personal trainer, doing awesome right now. Maybe you don't need as big a dose, just decrease it down a little bit. I'm depressed and sad and it's Christmas time and I feel horrible and I'm binge eating. Well, time to move up on the dose a little bit, make sure things. So could we have done those things? This is not a subjective measurement where you don't feel the effect. So I think that those are things we need to actually look at.
Thank you. Jan.
Hi, yeah, my name's Jan Davis. I thought your talk was excellent. I have quite a few questions. I'm trying to pick and choose, but one is those, and I apologize if I missed this because I missed a very brief portion of your talk, but do you think those set points in an adult could be affected by obesity in childhood and changing obesity in childhood? That's one question. And another one is, do you think that having lost the weight, that the fact that people I've met who have lost a lot of weight are then feeling much more able to, get on the gym shorts and go for a walk, ride on a bike, they feel less embarrassed or even just physically more able to. Do you think that change might be one of the ways in which we could eventually get people off these medications because they were able to change their behaviors more effectively? And I am going to ask a third question, sorry, and that is, do you see this as a problem at all for our society, which is really, really focused on losing weight? Are we going to have people with normal weight or 5 pounds to lose wanting to take these medications and stay on them? Sorry for so many questions. It just raised so much
Right.
that I've been thinking about.
Great. Yeah, a lot of things to think about, right? This is going to go into the world of the social realm and the world of people trying to answer these questions without a doctor's answering, with the Google answering it and a number of other things. So children, could that set point be changed if we treat children first? So we don't know the answer to that. The set point may be a genetic set point. So what we may be doing with children as we start to treat them is battling from them not getting up to that point. So they're trying to go to their set point, and we'll be using medications or other interventions to stop them from actually going there. The other theory is that the set point comes about only when you hit that higher weight. So So someone gets up to 350 pounds, that set point is always there, regardless of their bariatric surgery or other interventions. They come down to 225. They're still trying to get back to 350. And that's why they keep on going back up when you stop, when you take your foot off the gas. So those are two kind of theories. That one, it's already set from a genetic standpoint, and you could try to stop it from going there. Or two, you hit it, and then you get scar tissue in the hypothalamus, and you hit that set point, and then you try to push down, and you're always trying to end up going on back. So the next question was, could we do could the physical activity that they've learned end up working out better to keep the weight off? Possibly, but the challenge is that the reason why they're able to do the physical activities because they're not hungry and they're not sad and they're not struggling and using up their entire executive load to just focus on keeping their calories down, because the medication frees up their brain to do other things like go to work, take care of people, appropriately love themselves, appropriately love others, and go to the gym and do those other things. If that medication is not there to free up that part of the executive load, they're back to their previous self where they're struggling. They're just dealing most of the time with trying not to eat, trying not to go into Tim Hortons and maybe have 10 donuts as opposed to one. So that takes up their whole brain space, and therefore activity, which was never something that they intrinsically wanted to do, but everybody tells them they should do, and they're trying to actually do it. Right? They're genetically not programmed to be active. They're genetically programmed more so to be sedentary, to keep the weight on. That's their genetic programming. Yet they're going against it every time we tell them to exercise, and they want to exercise because they know it's good for you. So I believe that the exercise that they're going to get when they're on the medication makes them stronger. It doesn't necessarily keep the weight down and have a big impact. It just makes them a better person, makes them not have Alzheimer's. It helps their diabetes to be better. It does all these positive things, but not a whole lot in terms of weight. The weight is the brain neurochemistry and the medication. And the final question was, do we think that it's going to make people, other people are going to actually use it? I think possibly and probably. We know that Kim Kardashian has tweeted and Googled about it, etc. So that's going to be up to them. It's not going to be us. It's not going to be our problem. We as physicians are going to do the right thing and prescribe appropriately and take care of people. Maybe we don't always have to focus on sick care. Maybe we'll have family doctors focusing on health care. My dad or mom lives with obesity. I'm on my way up. Can I get some medication? Yes, that sounds appropriate to keep things down. But the idea of, I'm a BMI 21 and I want to be a BMI 20 to get into a bikini, that's not going to be us or physicians. Will it be the black market? Maybe. Things like Viagra is sold to people in Las Vegas who are doing the wrong things, and it's in the black. So that's not going to be our challenge. Our challenge will be to always do the appropriate medical intervention, and it's not always sick care. It can be health care as well, stopping people from going up. So I think we have a couple of things to do.
That's really helpful. Deb Zimmerman.
Hi, Sean. Thanks for a great talk. My interest for a long time has actually been in helping patients who are on dialysis achieve a weight that makes them candidates for renal transplant for all the reasons that you talked about. And, this, I feel like this is another example of renalism. You can't use these drugs in people with end-stage kidney disease because of a lack of data. Can you tell me if there's really decent pharmacokinetic reasons why we couldn't actually use lower doses of, say, Semaglutide in the ESKD population?
Yeah, I believe that you all know online that you can use almost any medication in the ESKD patient. And so I really think that that you can use these medications. There's no data. There's no it's not cleared renally. There's no major issues that we know of. So I know lots of patients on dialysis on GLP-1 analogs. So I don't think that we are in a position where we cannot use it. I just think we're in a position where the product monograph states that there isn't any data. I think it is renalism, and I think that that the nephrologists should be using it, and I think nephrology, your nephrology colleagues should end up backing you up if something goes south. That's how I think of medicine a lot of times. When I think of, can I do something that's not in the product monograph, I think, is my colleague going to back me up if something happens at and I have to go to the college level, and I would hope that I would back you up, and I hope your other nephro colleagues would also. So I would recommend using it based on your capacity as a nephro.
Thanks,
you.
Sean.
Yeah. So that was also going to be my question. And if other people have, we have 4 minutes left. So if there are other questions, please raise your hand about the renalism issue, because we use drugs off-label all the time in nephrology. So we should be brave enough. As far as I know, and you can correct me, Sean, it's not contraindicated, right? It's a lack of data of these drugs in kidney failure, which is why it's sort of not recommended. Is there any adverse events or adverse effects that we should be worrying about?
Yeah, not that I know of. I mean, hypoglycemia would be one that you would want to look at, but certainly I don't think that this can be a factor unless the patient is on insulin. And even their monitoring would be the best thing. Otherwise, I don't know of any, right? It doesn't cause more pancreatitis, it doesn't cause more gallstones, it doesn't cause more nausea and GI upset. I mean, there's no other reason. And this is with the GLP-1 analogs, the naltrexone Contrave, the naltrexone bupropion combinations. I think there's more there because there's less data there, and there's not going to be more data, right? The drug itself is run by a company that doesn't do clinical trials, right? They bought it, and they're not a pharma company that actually does that. So I don't think we're going to get data there. But with the GLP-1 analogs, I believe that we'll get more and more data, and I don't see any adverse effects that I would be concerned about.
Fabulous. So hopefully going forwards, we will be, using these drugs apart from everything else we do to combat the obesity epidemic in our populations as well. That was a brilliant presentation, Sean. Thank you again, and thanks, Anne, for making the connection for us to do this. For all the listeners, you will be getting an email with the evaluation. Please fill it. We look at it, and we give feedback to the authors, to the presenters. Also a reminder in housekeeping terms that we will not have rounds for the next 2 weeks. We have other meetings, and rounds will resume in the first week of December. Thank you, Sean.
Thank you very much. I appreciate it from everyone's standpoint. Thank you.